Good afternoon, everyone. I think it's time to start. My name's Kathy Piccoli. I'm co-director of Women's Imaging at South Jersey Radiology in Voorhees. Before that, I was director of breast imaging at Thomas Jefferson University Hospital in Philadelphia. I've been doing biopsies since about 1988, and so I've done a few. So I am here to tell you about my experiences. So my objectives are to look for potential problems prior, during, and even after the interventional procedures, and to describe how perhaps to prevent and mitigate any problems that may come up. And does anybody know where this is? It's the East River in New York, where the Harlem River comes in. It's a very narrow area that just has a tremendous current because it's so narrow. And the water just boils. It's all over the place. And you really have to hold on your tiller when you're going through this area. And it's called Hellgate, which I thought was a great way to start our biopsy lecture. I'm mostly going to talk about large gauge core biopsies using ultrasound, stereo, and MRI guidance. I won't really say too much about needle lokes or FNA. What could go wrong? Well, just about anything. And you know, I've seen the wrong lesion biopsied, the wrong side, the wrong patient issues. We've had plenty of equipment problems, complications, and then a variety of other things like allergic reactions, problems finding the lesion at the time of biopsy, all sorts of different kinds of things. So I'm going to go through some of these topics. It's not that hard to biopsy the wrong lesion, and why does that happen? Well, probably because we may not be paying very close attention to the imaging or the reports or what the referring physician is telling you. And miscommunication can be a bit of an issue between radiologists, between the radiologist and technologist, and between the radiologist and your referring physician. But it's also possible to just misread the report, and if there are change in management plans which the biopsier doesn't know about, then you can err along those lines as well. This is just an example of poor communication. So back when I had fellows, I had a surgeon come in and talk to me about a patient where he wanted us to needle loke a particular lesion, not the one that we were planning on loking for him. So I took the information and then turned around and gave it to the fellow who was going to be doing the localizations on the day the patient was coming in. And I was very unhappy to have the surgeon come back at us, very upset because the wrong lesion was localized. And when I went to the fellow, I said, well, what happened? He said, well, I didn't do the lokes that day. So I was like, you know, and this was like a personal assault on me. You know, what should I have done? I mean, really, I gave it to him. He should have done what I told him to do. But, you know, I look back and I think, I could have done more myself. I could have written plainer notes. I should have done some circling, anything so that we did the appropriate thing for this surgeon and the patient. So I've become very persnickety about reporting. And when I read a report, I don't want anybody to have any question about what I'm saying. And when I read a report, I don't want to have any question about what they're trying to tell me. So I've asked our group to number every lesion that they think is important and describe it accurately and using BI-RADS terminology, which is still a problem. I'm still getting bizarre words come up in these reports. I mean, BI-RADS has been out for years and years and years, and yet I'm still getting very odd language. We also need to annotate our images very carefully. Arrows, you can write on, the screens, and, we don't have film anymore generally, but these annotations can go along with the patients on a disc if you hand that to them. So you have to be really careful about what you want biopsied, particularly if there are multiple masses, multiple calcifications. Which are the ones that look important to you and need to be biopsied? So, and the recommendations have to be very clearly made in the report. This is an example of what I call a run-on paragraph, a breast ultrasound. At 10 o'clock, about 1 centimeter from the nipple, there's a solid lobulated mass with internal color flow. The mass is elongated and measures 19 by 7 by 12 millimeters with somewhat lobulated margins. A little redundant there. It does not transmit sound and is oriented parallel to the skin. So at least he's thinking BI-RADS there. But is all that really necessary? No, you can kind of cut to the chase. And then he does say ultrasound-guided needle biopsy is recommended, but then goes on to another lesion in there. So, it's like one lesion after another, and you're just reading way too much to get the point. And this is kind of the way I feel when I read these run-on paragraphs. It's just like navigating through fog in Maine. So make your reports concise and clear. And this is what I like to see. 1 o'clock, retroareolar. Describe the mass, its size. Next one, 9 o'clock, areolar margin, oval, ill-defined hypoechoic mass, and on at each location. And then we're saying we see 3 suspicious lesions. Biopsy those 3 masses at 1 o'clock, 9 o'clock, and 11 o'clock. So be clear, be precise. And if the recommendation changes, document it. And that may be verbally, it may be on the films, and it may be an addendum to the report, but document it. Okay, so what other problems can we have? Well, the wrong lesion. Patients with multiple lesions are a bit of a problem. And it can be a little bit difficult to find the lesion that's recommended for biopsy in patients with a lot of different findings. And there are also problems going from one modality to another. So here's an example of a patient with multiple small masses scattered throughout both breasts and no old films. So this is what I think of when I look at cases like that. It's like looking up at these tall ships and wondering, what on earth am I supposed to do with this, Anyway, they focused on the right side in this particular patient and ended up doing ultrasound and listed at least a dozen lesions. Every single one was called a lesion from 1 o'clock to 12 o'clock. All around, and the recommendation was get an MRI. So it's like, okay, great, we'll get an MRI, and you know how that's going to go, right? So anyway, I'm going backwards, sorry. They did find a couple of enhancing masses that were a little different from most of the others. They had a little bit of heterogeneous enhancement in there, coupled with some progressive and persistent flow. And they felt that one of these correlated with this 9 o'clock lesion on the ultrasound, so recommended ultrasound guided biopsy of this. And then they saw another area of ill-defined non-mass enhancement, which had a little bit of persistent flow in it. And then they went back to the mammogram and felt that they found it, circled it, did exactly what they're supposed to do. And then she came for biopsy. They had also recommended biopsy of something right behind the nipple as well. So we did 2 ultrasound-guided biopsies and a stereo biopsy of the more posterior inferior mass, and then got our post-biopsy mammogram. And the 2 that we did by ultrasound were not an issue, but the biopsy that we did by stereo showed that the clip was way high in the breast. So it just did not correlate with the finding on MRI. And maybe I biopsied that circled lesion from her diagnostic mammogram, but it was really difficult to figure that out at the time. And so now what are you going to do? I mean, this poor lady's been through 3 biopsies that day. She really was not interested in us working on her anymore to find another lesion to biopsy. So at that point, my management plan was, well, let's find out what the results are. And if it's positive, then we probably should do an MRI guided biopsy of this other lesion that we missed. And if all biopsies are negative, then we could consider an MRI biopsy of that other lesion, or at least follow it. So at least we had a plan there, and we didn't leave it open either for conjecture, for the referring physician to think about when the results came in. I gave them a plan. This was the plan, and there actually was a cancer here. Does anybody want to guess what it was? Which one? It looked pretty bad to start with, to tell you the truth. Taller than wide, it has a little halo, maybe a little shadowing. Didn't look all that different from the lesion under the nipple, except that really did kind of look like a duct when I scanned it, so I wasn't too worried. And then the third lesion was benign, and then we had to go into our management plan of doing an MRI-guided biopsy for that lesion. Another case. On her initial workup, they found a focal asymmetry and sent her to biopsy. There was no ultrasound correlate, so it was a stereotactic biopsy. And I looked at it, and when I first looked at the images, I thought that just kind of looks like tissue, except it really was a new finding, so it deserved biopsy. So here's our biopsy. And you can see the diagnostic images, and then we put her in stereo in the craniocaudal projection, found the asymmetry, did the biopsy, and we actually used 3D to do it. And then we got our post-biopsy mammogram, and the clip couldn't be farther away from the lesion in the inferior part of the breast. It's kind of like a lot like that other one. And I looked at that and I thought, oh my God, now what? You know, this poor girl, and she was young. She's like, I don't want to do this. I don't want to have to go and do it again, but you have to do it again. This was a new lesion on the mammogram. And so we did the whole thing over again. And in the end, you can see where the triangles are. That's where those were where the lesions matched up on the MLO and the CC views, and then the circles matched up. So she actually had 2 asymmetries that developed over time that we ended up biopsying, both of which were just stromal fibrosis, but it was appropriate that they got biopsy. It's just too bad that it didn't get worked up appropriately the first time. Nevertheless, you've got to do what you got to do. You got to get the answer. Okay, this is one that I'm really not proud of, but I want to tell you about it because it can happen. So I was doing an MRI guided biopsy, and I talked to the patient beforehand, signed her up, and then walked into the control room while the techs put her on the table. And then I walked back in, and I usually put a fiducial in a spot where I think is appropriate before I do the biopsy. Stuck the fiducial on, the techs had already put her in compression, walked out, we did the, gave her the GAD and imaged her, and I couldn't see the thing. I was like, okay, let's do a delay. Let's see if it pops up. And so we did a delay, and there was a little bit of enhancement in the area where I thought the lesion should be. So I went in, cleaned her skin, numbed her up, made a little incision, and the patient said, "Dr. Piccoli, I thought it was the other side we were doing." And, at which point I started sweating and my heart started pounding, and I'm thinking, is that why I couldn't find the thing to start with? So, and the techs are saying, "Oh, no, we're on the right breast, don't worry." And I said, "You know what, time out. Let's just go check, okay?" Yeah, sure enough, I had signed her up for the other breast. The report was for the other breast, and the tech had put her in for the wrong breast, and I didn't notice. And, I use sagittal images when I'm setting them up, so one sagittal looks like another sagittal. And, well, I was really distraught over this one, but, I came back in the room and I said, "You are absolutely right. We're just going to put your breast in compression, the other breast in compression, and put you back in the magnet to look at that one." And we did. We gave her a little squirt of GAD, found the mass, biopsied it, and the patient was just lovely. She didn't seem to care at all. I'm like, thank you, God, thank you. But yeah, it can happen. So ever since then, we'll go in the room, the tech will say to me, "Dr. Piccoli, right breast?" And I say, "Right breast," and we'll ask the patient, "Right breast?" The patient will say, "Yeah, right breast," and we'll move on. But we never, ever want that to happen again. One of our radiologists did a biopsy for a very suspicious mass, and she got back a histopathologic result of benign fibroadenoma or something like that. And she was not real happy with that result. So she called the pathologist and explained, and the pathologist went back, looked at the slides, and came back just as horrified as I was when I did the wrong breast, that, yeah, she made a mistake, that she reported on the wrong patient. So just another example of why we have to be very careful about correlating our imaging and path results. So I'm going to go through some of the little equipment problems we've had, actually fairly recently. And this is an example of an equipment that got replaced recently. It was his shoulder. And, from years of abuse, he finally couldn't paint his boat, so he got his shoulder replaced. And sometimes we have to do that with our equipment, too. So mostly this happens with our vacuum-assisted devices. In this particular case, we got the needle in position in the breast. We fired, we attempted to sample, but we didn't get anything. And in fact, there was a hissing sound from the biopsy device. So and obviously there was a leak somewhere. It wasn't anywhere where we could find it. So out comes the needle, and we replaced it with another device, and it worked absolutely fine. We did not, however, remove the introducer that was already in the breast. So it was pretty easy on the patient, just one gun for another. Another example, we got the needle in the breast and fired it, but it did not advance automatically. So I said, that shouldn't be that much of a problem. I'll just dial it in, okay? So we did that, and this is pre-fire, post-fire. You see it didn't move at all. So I dialed it in, and it moved, and then began to take the biopsy, at which point nothing happened. Didn't even get the hissing sound from it. It was just like blank. Nothing. So same thing. I mean, you just, you leave the introducer in place, take it out, and replace it with a gun that actually works. And this one worked. Okay, this was quite a story. So MRI guided biopsy, the patient's on the table, she's already been imaged, so GAD's been given. I found the lesion, cleaned her skin, numbed her, got the introducer in, got the little obturator in, we did our imaging, we were in good position, got out the vacuum-assisted device, and it had just gotten back from refurbishing, and there was something that wasn't quite stuck together yet. And so the techs started to put it together, tried to put it together, pushed it in, couldn't do it, and basically I didn't have a biopsy gun to use at that point. So, I use the ATEC device. So we have an ATEC device in ultrasound. So I thought, oh, let's go get that, So we called over, somebody comes, running out of the department, through the courtyard, up to the MRI suite with the ultrasound console. And then we look at it and realize, well, the MRI gun is not compatible with the ultrasound console. So, okay, now what? Well, we could get an ultrasound needle. Okay, fine. So we had to go running back to ultrasound, came back to MRI. And then I look at the gun for ultrasound, and I look at the gun for MRI, and the MRI needle is, significantly longer than the ultrasound gun. I'm like, I can't believe this is happening. At that point, I couldn't use the ultrasound gun with the introducer in place because it was just too long. So I had to pull it all out. And I just went in freehand with it. And I measured the approximate distance it should be and where it was and zapped away, and we got a fibroadenoma out of it. So I was very pleased with myself, but that's just a little traumatic on everybody, I think. But sometimes just you have to think through it and persevere. This was a weird one recently where we did a stereotactic biopsy on faint calcifications. It was so hard to see them. And I'm not even going to say, hey, see those? No, you can't. You can maybe see the green circle, but you can't see the calcification. Very, very hard. We did stereo scout images, we did tomo scout images, and we found them. We got the needle in there, we did a first pass, we did a second pass, and we're just not seeing the calcifications. So I thought, well, maybe we should try to retarget. So we took the needle out and took an image, and it's probably isn't showing well for you, but for us, when we were there, the images were just so grainy. There was no way we were going to find our fine little calcifications here. And the technologists could not figure out at that moment what was going on, what was happening. So, we're there like, okay, now what do we do? Well, all I could really do was stick the gun back in and take more tissue and just sort of cross my fingers. And, this is what it looked like, by the way. This is dew on the isinglass on the canvas on the boat. But it had that really grainy appearance, just, no detail, really. So we reinserted the needle and just took a bunch more pieces, and we were very lucky to get them on one piece. But just another, you don't need that kind of trauma to yourself when you're doing these biopsies, but you got to work through it. And just another case where we did a successful biopsy, and it was time to put the clip in, but when I went to put the clip in, there was no introducer. And I was just like, well, where's the introducer? And we looked at the needle, and there's no introducer there. And then we looked in the box, and there it was. It had never been stuck on the needle to begin with. So the poor tech who didn't put it on the needle she was so apologetic, the poor thing. And I said, it's not that big a deal, So I just sort of figured, well, we'll just go in the hole that's there. And I placed the clip through the hole. And I don't know how good a job I did because it was a little bit displaced, but we got through it. We did the biopsy. But just a word on biopsy clips. I think they're really, really important. And the reason is because we have surgeons who do their own biopsies, and they often don't leave clips, and then they'll send them for follow-up. and we want to know what we're following, because we don't know where they did their biopsy. So we don't know, they commonly don't even tell us what they got when they did the biopsy. Just do the follow-up. But at least if they leave a biopsy, we know where the biopsy has been done. And if it was benign, we have a say as to whether or not, yes, I think you did get it, or no, I don't think you got it, it needs to be rebiopsy. But to us, it's a visual history. And I can't tell you how many patients have had biopsies in the more distant past, when they were younger, maybe before they had mammograms. So we don't have documentation of whatever was biopsied. And no clip was placed, and then they get their first mammogram and they have a mass. And they'll say, well, I think that was biopsied before, but we don't know that. We don't have the documents, telling us that that's what was done. You leave a clip and we'll always know what was done. So I think they're very important. And if they migrate, document that they've migrated on the images and in the report, because if you have to go back there to remove the lesion, you may want to go back to where the lesion is or was rather than go after the clip. And here's a problem that comes up every once in a while where you place a clip, but then you can't find it on your post-biopsy mammogram. And this is just such a case. And you kind of hope that the biopsy is benign, but in this one, it was radial scar and ADH, so they're going to have to go back in. And, so now what do we do? Well, you can hope for a little bit of residual lesion there, the mass or the calcifications or the architectural distortion. Sometimes there'll be a little hematoma, so you could localize the hematoma if they come back soon enough before it vanishes. And, once in a while there'll be landmarks like calcifications or that sort of thing that are nearby, so you can use those. But honestly, if it comes about that you got the clip in there and you have no imaging finding left over to guide a surgeon to their ADH or whatever, it can be very problematic. At that point, you just have to do the best you can do. And I had one case where I did 2 biopsies under ultrasound guidance. 2 clips were placed, but one got dislodged. It wasn't there on the post-biopsy mammogram, and that's the one, of course, that needed to be removed surgically. So we sort of guided the surgeon based on where the other clip was. So this is a beautiful sunset in Maine, and it looks like a bleeding heart, right? Or a bleeding sun. Anyway, we're going to talk about bleeding now. So complications. I always tell the patient when I sign them up for biopsy that the complications could be hemorrhage, infection, and damage to adjacent structures. And damage to nearby structures could include lung. That's rare, but it's happened. Not to me, thank goodness. But I had a surgeon friend who wasn't really watching what she was doing. She just took the syringe and she was poking around. She knew exactly what she did, poking around. And patient came back the next day complaining of shortness of breath, and she had to have a chest tube. So it can happen. Implants, certainly we want to be careful about. And, once in a while you're going to get skeletal muscle in your biopsy for really deep lesions. Usually doesn't do anything to the patient, but they could be kind of sore afterward. And axillary contents is another area altogether that we have to be careful about. So let's see, in a recent paper, they looked at complications and divided complications to minor, moderate, and severe. Minor being bruising, hematoma not requiring treatment. I get lots of those. Slight discomfort afterward. A lot of patients have a little discomfort for a while afterward. Nausea, lightheadedness, or skin irritation. Moderate they call outright bleeding. Pain, vasovagal reactions, severe enough to stop the procedure, or bleeding on with prolonged compression, and severe post-biopsy infection or bleeding requiring surgical intervention or death. was like, oh my goodness. I mean, hopefully that's never going to happen to any of us here, but a lot of the other things will. So overall, core biopsies are really pretty safe. In one report of well over 4,000 stereo vacuum-assisted biopsies, they had 307 minor complications, 12 moderate. Of the minor complications, most were hematomas, and the other was a complaint of pain. So hemorrhage really is the greatest risk, I think, and we always think about the anticoagulated patient or the patient with any kind of bleeding disorders. Also, vascular lesions I'll sort of look cross-eyed at, and we want to consider lymph nodes fairly carefully. But even in anticoagulated patients, there have been reports out to say that large gauge vacuum-assisted core biopsies are essentially safe. And in one report of the 11 gauge biopsy, they got hematomas in 3 of 5 of their anticoagulated patients, and the largest hematoma was 40 millimeters. The hematomas in the not anticoagulated patients were not rare, but they tended to be smaller. And you do get, I think, less bleeding with a smaller biopsy needle. But I'm not using those needles anymore, mainly because I want really good tissue for the pathologists that we have to send our cores to based on the patient's insurance. So we're an outpatient facility. They have to go to outpatient pathology labs. And we don't always trust those pathologists. So we want to give them as much tissue as possible to make a diagnosis. So I very rarely use an automated throw type gun anymore. And in another study, anticoagulated patients versus not, bruising was more common in the anticoagulated, but they saw hematomas and bruises with palpable hematomas in all of the patients. Well, this is a patient that I did an MRI-guided core biopsy on. She had been on Plavix, but her physician stopped it for the procedure. And I did 2 biopsies, and one went very well, no bleeding, no problems there, but the other one was absolutely horrendous. She developed a 7-centimeter hematoma, and she was extremely uncomfortable, in a lot of pain. And initially when she called me about bleeding, I probably wasn't as attentive to her as I should have been, because later she wanted to sue me. So I was like, okay. But she ended up having this evacuated, and I didn't get sued. This was another one that had to get evacuated, another MRI-guided biopsy, in a patient, when I signed her up, who said that she had also had excessive bleeding when she had a thoracic spine meningioma removed. And she had gone through some testing, and there was no evidence of any blood dyscrasia. So, we shrugged our shoulders and went ahead and did the biopsy. And then immediately after the biopsy, I see this hematoma. And sometimes you see them that big, but I just did not have a good feeling about this one. And so we kept her in the department for a while, and finally, she was oozing a little bit, finally stopped, went home. And the next morning, I get this phone call from her surgeon, and she said, "Kathy, just wanted to let you know, the patient came to the hospital last night, and, we took her to the OR for her great big hematoma." Anyway, I called that patient, and I felt really badly, and she said, "Oh, Dr. Piccoli, I'm so sorry I did this to you." I was like, well, wait a minute, I think it's the other way around, She was so nice. But anyway, Here's a patient who had distortion on her mammogram, and on ultrasound we saw some ill-defined tissue, taller than wide, little lesion there, and just some funny architecture in that area. So we felt we could do the ultrasound-guided core biopsy, put the needle in. The other thing was, she said she was sensitive to some kind of dental injection. She didn't know what it was, and we weren't sure. So we gave her Marcaine to numb. We didn't give her any epinephrine, as we usually do, and that may help decrease the amount of bleeding in many of these patients. But anyway, I put the needle in, and just as I stepped on the pedal to, take the biopsy, I see this round thing kind of pulsing right in the bevel of my needle. And I'm like, no. And it got it. And immediately the cavity starts filling with blood. And I quickly took another few pieces and got out of there, got a clip in. But she developed a really good-sized hematoma like that. I mean, it was totally immediate. I mean, it was arterial. So we ended up holding compression for about an hour. And on the right is what it looked like when we finally let her go. It was about 4 centimeters. You could see that the blood had just sort of dispersed through the tissues, and her skin was yellow. It was like that size area was yellow. I mean, it was big. Anyway, she did fine. She did call me a couple weeks later and said, I'm really kind of purple. Is that normal? And I said, well, yeah, for what happened to you, it is normal. For axillary lymph nodes, this is what I usually do. For a patient with a known or an absolute, BIRADS 5 mass in the breast, so a known malignancy or a very suspicious lesion, if she has an abnormal lymph node and they want it biopsied, I'll do FNA. And I usually use a 21 gauge. And if it's an obvious abnormal lymph node, I almost always get malignant cells, and that's basically what they want to know. Are there malignant cells there or not? However, in the case of a known or suspected malignancy and there is an equivocal lymph node and they want it biopsied, I'll use core biopsy for that. Because I just don't think that you're apt to get enough tissue with a fine needle aspiration biopsy when you're not 100% sure where to put that needle. And if it comes back normal, then she still has to go get another biopsy. So the other case where I'll use a core biopsy or a vacuum-assisted biopsy, which is usually what I do because that's what I have, is in patients with suspected lymph node metastases or question of lymphoma. Because I don't want to just know that they're malignant cells, though. We really want to try and make a diagnosis for the patient. And if you look at the literature, the pathologists do prefer core biopsy over fine needle aspiration biopsy. And there have been a number of reports out showing safety using different size core biopsies all the way down to 12 gauge. And it's been shown that there is increased sensitivity with the more number of passes you make. This was with a 14 gauge biopsy. And in this particular report, both FNA and core biopsy were least sensitive when the node appearance was least abnormal. So again, I'd prefer to do core biopsy in those more normal looking abnormal lymph nodes. And they also found that core biopsy had no more morbidity than FNA, even when using up to a 12 gauge needle. And from the pathologist's point of view, they say although flow cytometry from corresponding FNA specimens when trying to establish a diagnosis of lymphoma, it did not add value to the subclassification of a lymphoma, which the oncologist needs to know to be able to treat the patient appropriately. So they want to be able to see the architectural pattern of the lesion, and even the small core needle biopsies are an issue for them, but they really don't like fine needle aspiration and flow cytometry for diagnosing if they don't have to. That said, this 80-something-year-old woman came to us with a palpable axillary lymph node, and I ended up getting her because it's in the axilla, and anything in the axilla goes to breast imaging. And her mammogram was absolutely normal. There was no sign that this was going to be a breast primary, and if you looked around a little more, she had multiple lymph nodes that were enlarged on that side. And I thought, this is probably either going to be metastatic from some unknown primary somewhere or lymphoma. So I used my core biopsy needle and took a couple pieces, and we got the result we needed to get. We got everything they needed to know. However, a couple days later, I get a phone call. Kathy, so your patient showed up in the ER, and they did a CT scan, and she has a tremendous hematoma from that biopsy. And so this is her CT scan, and this is her hematoma, humongous. You can see she's all infiltrated in her soft tissues. There's my clip. I'm glad I got that in there, but huge. Oh, and I felt so bad. They ended up transfusing her 2 units. That's like the worst for me ever. So, I look back at that and I said, well, yikes, maybe I really shouldn't have used that bigger needle, but really at the time, that's all I had on hand, and we did at least get the diagnosis. And, so I was dealing with the patient's daughter, and when I found out about this, I called the daughter, and I said, I am just so sorry this happened to your mother. And she says, it happens. It's like, oh my goodness. Got out of that one too. So, no, not really. I don't want to do this to patients. So I may use maybe a 14 gauge next time. We'll see. So be careful of vascular lesions. This was a patient who had ADH at ultrasound-guided core biopsy. They sent her for MRI to see if there are any other lesions or the extent of the lesion. And nearby her biopsy site, we see this enhancing mass with washout in the center of it. And so we go back to ultrasound to try and biopsy it, and we find this little mass with tremendous blood flow in it. In fact, kind of to and fro blood flow, right? So you know what this is, right? It's a pseudoaneurysm. And definitely didn't want to biopsy that. So they removed it when they went in for the ADH. Here's a patient with a history of LCIS, getting screening MRIs, and she has a new tiny little enhancing mass in that left breast. Can you see that little dot right there? And there it is, sagittal, and it's sitting right on a blood vessel. And here's the MIP. There's that blood vessel coming around, and it takes this nice little sweep just to hit the lesion and then sweeps away from it. And guess who gets to do the MRI biopsy? So I look at that, and I don't want to do that. It's just like too ripe for complication. Anyway, we did the biopsy. Here's her lesion. Here's her needle, and I figured the lesion was probably right underneath it, and that was probably the vessel we were seeing right there. And so I thought, well, it's right underneath it, so I will take, one bite here, one bite here, one bite here. So I took 3 bites, and I said, I'm not doing any more than that. And this was her post-biopsy appearance. Very little blood at all. She had absolutely no problems, no hematoma, no nothing. we got a diagnosis of lobular neoplasia, and I couldn't believe it. Just couldn't believe it, but count my lucky stars. This patient was a very fragile 77-year-old. She'd been diagnosed with DCIS the year before, treated with lumpectomy only, came back for a mammogram, and now she has multiple masses throughout this breast, and they all looked like this, with large vessels running through them. And you know, I just looked at this poor thing, and the last thing I wanted to do was give her a hematoma. And so this is one time when I decided to do a fine needle aspiration biopsy, because basically they just wanted to know if this was recurrence of her malignancy. Let's find that out, and we'll do the, you know, a mastectomy if it is. And yeah, so with a fine needle aspiration biopsy with a very suspicious looking mass, yes, you can get malignant cells out of it, and that's what we got. And with very little problem with the biopsy. So for patients with elevated risk of hemorrhage, if I can do an ultrasound-guided biopsy, I will do an ultrasound-guided biopsy, because you, like most of the time, you can see these larger pulsating blood vessels before you start the biopsy. But you can try to avoid the large blood vessels. And as I did in this last case, if there's a big risk of hemorrhage, you can do a fine needle aspiration biopsy. Also, when they do bleed, they are already in optimal position to apply compression to the breast. They're lying there, and you can lean on that breast. Whereas in an MRI or a prone stereo table, they're hanging. And I think that helps the bleeding somehow. And then you have to flip them over, and then they're not in a great position. And, but with ultrasound, you know exactly where you did the biopsy, and you put your hand over that. So that's my preference. When we schedule them, we have our schedulers screen them for potential bleeding issues, and we've had discussions about this among us. Should we stop their aspirin? Should we stop their non-steroidal anti-inflammatories? And we decided, no, we probably don't have to. We can tell the patient she can if she wants to, unless it's medically necessary, and then she really needs to discuss it with her physician. However, in patients with other forms of anticoagulation, there's usually a real medical need for it, and then you really have to talk to the physician about that. Okay, change of topic. This is a beautiful day in Maine, except we see this line of clouds coming, and that's called a front, and that warns you about impending weather, like this, for example. And when my tech comes into the room before a biopsy, and she looks at me with squinty eyes and says, "I'm not sure you're gonna like this patient," she's my front, and that's what I'm gonna expect when I go in the room. So difficult patients. Now there are patients who, are physically disabled. They're difficult to position. Sometimes you're biopsying patients in a wheelchair. I mean, you deal with that, right? And language barriers. Hopefully you can get somebody to interpret for you. Cultural differences where there's some women who don't even want to open their blouse, so you can get to the breast. But those you can usually get through. It's the personality problems that I think really drain you. There are some patients who are just so sensitive. You touch them with a Q-tip and they scream. Or you get the patients who are tremendously anxious, and you have to hold their hands. Sometimes you have to have somebody in the room holding their hands, their husband or their daughter or whoever. And then some patients are just suspicious. They want to know what you're doing. They want to know who you are. How many have you done? It goes on and on and on. And it can kind of wear you out. This is an angry bird. So I see angry birds at work. But when I go in and see these patients, I sort of steel myself and I try and tell myself, these patients are having a hard day. They're anxious about the procedure. They don't know anything about it. They don't know anything about me. And they're also very worried about the diagnosis because nobody's looking forward to a cancer diagnosis. Sometimes you have to deal with their very anxious support group too. If they tell me they've taken Valium or something, I say, that's great. Yeah, that's fine. I don't mind that at all. But to make your patient comfortable, I usually walk in the room with a smile and I say, hi, I'm Dr. Piccoli, how are you? And start telling her what we're going to do. And, sometimes they'll tell you that they're really scared and, you just sort of calm them down. Usually while I'm getting ready, putting my gloves on or, just cleaning off the breast, I'll ask her questions about herself. Did she come with anybody today? What do you do? Did we take you away from work? And then you get a conversation going, and after a while, they really do feel a lot better. And I had a patient like that the other day, So, the tech comes to me, the front, she says, this one's a bad one. She hates needles. And so, okay, went in there, started talking to her, and she just glared at me. And I started trying the conversation thing, and she would give me one-word answers. She just clipped one-word answers. Finally, I find out that she used to be a nurse, and I said, oh, well, you must have given needles, right? And she says, yeah, I gave lots of them, but I don't like getting them. And then she just started talking, and she started talking about how she was in medical ICU and blah, 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 blah. And before you know it, we were pals. And it just, kind of have to break the ice. And things usually turn out okay. And the other thing I want to just note is show your own self-confidence, but do not be arrogant. They sense the arrogance, and they really don't like that. But if you show them that you know what you're doing, and you're doing it competently, and at the same time you're trying to make friends with them, they usually soften up, and they're okay by the end of it. Like our Angry Bird's now our friend. Okay, well, you might think this is an intro to ultrasound and shadowing, that sort of thing, right? But no, this is about going to ground. And it can be a long way down for some patients when they're sitting there with their breast in compression and skewered by a needle, right? You do not want them to faint on you. But it can happen. So vasovagal reactions, sudden and intense widening of venous blood vessels combined with decreased heart rate triggered by stimulation of the parasympathetic nerve system, which means an increased quantity of blood remains in the venous system and less blood circulates back to lungs and heart. So you get a decrease in your blood pressure, a decrease in blood circulation, and you lose consciousness. And it's not a terribly infrequent thing to happen, particularly in patients who are getting upright stereo biopsies or they're upright for their needle localizations. We see it a lot less when they're supine or prone, but they can get some of the prodrome. So they may feel a little nauseated, or they may feel sweaty, diaphoretic. It's the same sort of thing. Sometimes we'll ask if we have an inkling that maybe they're kind of the skittish type. We'll ask them if they have any history of fainting, and so we can be a little bit more prepared. But a lot of times it just happens to ladies that you would never have expected because they seem so well put together. We use a chair for anything that we do upright. It has wheels that lock. I do my best to keep the pain levels down, so I use lidocaine. I use buffered lidocaine because it takes the sting away, and sometimes patients don't even know you've put a needle in their breast when you use that. And then there's something called the how exercise, which you might want to try my little trick. It may or may not help, and maybe it's worth a try. Anyway, pain prevention, I use buffered lidocaine, as I mentioned before, and we usually use a 10-to-1 ratio, 1% lidocaine, 8.4% sodium bicarb. And what I usually do is numb the skin with this, numb deeper down around the lesion, and then I usually use Lido with epinephrine around the lesion and in the lesion to help staunch the bleeding issue. The How exercise was developed by a psychiatrist, and his aim was to let the person sense her own body, and it was an exercise where they would use a series of increasing and decreasing muscular tonal activities, basically like squeezing their arms or their legs, and they would do this step by step, up and down their body. But I read an article by a dermatologist who had issues with patients fainting on him, and so he sort of borrowed this exercise and had his patients do this before he did his biopsies, and found that it was helpful. Now, for us, we're probably going to ask them just to squeeze leg muscles, because we don't want them, using their arms at all. It can definitely move the breast in a compression device. But theoretically, it'll increase blood circulation, and hopefully it will increase venous pressure. And the other thing it might help is divert the patient's attention away from what we're doing to what her job is. And hopefully she won't pass out. However, if the patient starts feeling nauseated, diaphoretic, tells you she's feeling faint, then you got to act pretty swiftly. And I will immediately say, okay, take some nice deep breaths. The tech will slap on a cold compress, and we'll rub her back, and just, and then I'll tell her also, you know what, squeeze those leg muscles. Let's just squeeze them. And, sometimes they're going to pass out. But honestly, I haven't had a patient faint on me in quite some time. So, hey, maybe the How exercise really does work. You can try it. If they do pass out, hopefully you have some kind of procedure that you use so that they're not lying on the floor. I mean, in one mammo room, we had a big, thick gym pad that we had on the door, and if the patient started feeling poorly, then we would put it on the floor and help her down into it. But the last thing I like doing is putting her on that cold floor, and so we have Trendelenburg chairs in some places, and anyway, just have a little procedure ready for when it happens. Other reactions, such as sensitivity reactions, I'm not really going to talk too much about. It's rare to get reactions to lidocaine. They can get palpitations to epinephrine. If you inject it into the skin, they can get skin necrosis. That's a real reaction that you want to avoid, so please don't do that. They can get allergic reactions to GAD when you're doing an MRI, so you have to be on the lookout for that and ready. And they can have sensitivity reactions to the tape, the Band-Aid, or whatever you're putting on their skin to cover their cuts. So, you just want to be aware that those can happen. Infections also, thank goodness, are very rare. I will say they are increased risk for happening in lactating patients. And I warn the patients about that if I have to do a biopsy in a lactating patient. Usually the antibiotics that are used are either Keflex, or if they're allergic to cephalosporins, then clindamycin. And I have not had an infection in so long. I'm not really... I can't even tell you what the doses for these are right now, and I usually call my favorite internist anyway, if these sort of things happen for my own consult. But it's really extremely rare. Okay, next we're going to talk about positioning, and these are one design racers in Narragansett Bay, and they are positioning themselves based on where the other boats are, based on the wind, based on the current, and where their mark is. And there they are, they're jockeying for position to go around that little yellow mark, and we are going to talk about this positioning issues. You know what, I am really just about done here, I think. So beyond where I wanted to be, or I haven't gotten to where I wanted to be. Just a few little cases if you want to stay. I've got this implant case where it's very close to the implant. You can push that implant away to do your biopsies. This is a case where the implant's very close to the lesion, but again, you can push that implant away in some cases to do a safe biopsy. If the lesion is right on the implant, again, it can be safe if you're watching what you're doing, where the tip of that needle is at all times. You can put in a little lidocaine in under the lesion, between the lesion and the implant to increase depth. But it can be very safe to do these types of biopsies if you're very careful about watching what you're doing with the needle and where that needle, want to know where that needle tip is at all times. Sometimes where the lesion is, the position of it is a problem. We've had patients go from our one MRI location where we do biopsies because the lesion's so far back they could not get it with this one device on the left. And we go to the other place with the Sentinel coil where you can get way up high. This was one case I wanted to show you was this. It was very close to the skin, very close to the chest wall. I got her into MRI, decided I'm not going to do that. I put an X on the skin, brought her to ultrasound. All I saw was this little, the duct, small ducts in that area with a little bit of bump up of tissue. Biopsied that and got DCIS out of it. And just another case where it was a lesion very far back in the breast on MRI, very far back, but also very superficial. On MRI, I just put an X over where I thought the lesion was, brought her to ultrasound, saw nothing on ultrasound, put a needle in it under the X, and got a fibroadenoma out of it. So you can do clever little things like that too sometimes, even if you can't see the lesion. Okay, I'm kind of over, so I don't want to go over anymore. I'm going to stop. If there are any questions, I'd be happy to talk to you outside.